evening to all our speakers, chairs, and the wonderful audiences around the world. Welcome back to ACNS webinars. The speaker for the first session of today's webinar is our honored guest from Hong Kong, Professor Takla Poon. Professor Poon is the Deputy Chief of Services and Consultant Neurosurgeon, Clinical Associate Professor Honorary of the Department of Surgery, Chinese University of Hong Kong, and Coordinator of the Neurosurgical Services, including Stereotactic and Functional Neurosurgery, Epilepsy Surgery, Movement Disorder, and Endovascular Surgery also. His clinical subspecialties in neurosurgery include movement disorders, epilepsy surgery, awake craniotomies, stereotactic radiosurgery, and endovascular intervention. He is also a member of the Council of Hong Kong Movement Disorder Society and the Hong Kong Epilepsy Society, and the board member of the Executive Committee of the Asia Australasian Society for Stereotactic and Functional Neurosurgery. We are extremely honored to have him today at our webinars, and today he'll be talking about epilepsy surgery from basics to advanced. The speaker for the second session of today is our honored guest from China, Professor Qiling Chang. He is an attending neurosurgeon at the Department of Neurosurgery, Huashan Hospital, Fudan University, Shanghai, China. His research and clinical interests are focused upon treatment and translation research of cellular tumors. He is an invited faculty to various conferences worldwide, and we are extremely honored to have him today at our webinars, and he will be talking about integrated proteogenomic characterization across major histological types of pituitary neuroendocrine tumors. The chair for the first session of today's webinar is of distinguished faculty from India, Professor Malla Bhaskara Rao. Professor Rao is the professor and former HOD of Department of Neurosurgery at the National Institute of Mental Health and Neurological Sciences, Bangalore. He was the former president of the ISSFN and the former continental vice president of the WSSFN. He is a noted faculty with clinical interests are focused upon epilepsy surgery and functional neurosurgery. He is an invited faculty to various workshops and conferences worldwide. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Japan, Professor Masamichi Kurosaki. Professor Kurosaki is the chairman and professor, Department of Neurosurgery, Department of Brain and Neurosciences, Tottori University, Faculty of Medicine, Japan. He has a vast experience in the management of skull-based tumors, especially treating tumors of pituitary gland endoscopically. He is a member of Japanese Endocrine Society, Japanese Society of Skull-Based Surgery, and Japan Society of Pituitary and Hypothalamic Tumors. He has published several articles in various peer journals, and we are extremely grateful to him for accepting an invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the chair speakers and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online platform to our first chair, Professor Malla Bhaskara Rao.
Good morning and good evening to all of you. First of all, thanks for the opportunity. I will make a few brief comments, and then we'll go ahead with the presentation. So, as you are aware, there are 4 billion people in Asia, that is approximately 50% of the global population. We have 23 million people with epilepsy in Asia. And as you know, 60 to 70% of these people can benefit with medical management. Maybe another 10 to 20% are potential surgical candidates. So vast majority of these 23 million can actually benefit with both medical and surgical management. But unfortunately, in reality, there is a huge treatment gap, both medical as well as surgical treatment gap. You know, in Asia, at one end, we have centers in Japan, in Hong Kong, in Korea, in Taiwan, with offering very advanced epilepsy surgery programs, whereas in lower income countries, especially, even basic epilepsy surgery is not available. Thanks to the efforts of organizations like the International League Against Epilepsy, the Oceanian chapter of the ILAE, as well as Asian Congress of Neurological Surgeons, the epilepsy surgery programs are developing rapidly in countries with limited resources. In this context, I'm very keen to listen and learn from Dr. Poon about his experience as well as expertise in this field. I hope with these continuing educational programs, surgery for epilepsy will become an accepted treatment option. It will be a real advancement and a great service to people with epilepsy in Asia if we can standardize studies of the epidemiology, the burden, the causes, risk factors, as well as management of both drug-resistant epilepsy as well as epilepsy surgery. On that brief note, I invite and request Dr. Poon to present his webinar. Dr. Poon, please go ahead.
Thank you, Professor Rao. Your word is very true. I would say epilepsy surgery is one of the issue in many countries, including Hong Kong. It's not still not a very well established and have been although starting for many years. So I would like to take this opportunity to talk about something from fundamentals to advanced about all related to epilepsy surgery. And my hospital working in Hong Kong is Queen Elizabeth Hospital, and I am also the one of the executive committee members in the Australian Society for Surgery and Functional Neurosurgery. So, being a functional neurosurgeon, I really thank ACNS to give a chance for me to share my view on these topics. So I have nothing to declare. So we talk about epilepsy surgery is almost more than 100-something years starting this kind of surgery in worldwide. And you can see this is a summary of some milestones since more than 150 years ago when Victor Hoxley started the first craniotomy for removal of the irritating epileptic foci, and then followed by our giants in the world performing different kind of surgeries for treatment of the epilepsy. And then with the advancement of the technology, including the development of the MRI scan, we now have a more and more sophisticated surgery performed by our neurosurgeons with interest in epilepsy. So this is all the structures and photos taken by the previous surgeons related to their operation. And you can see there's a lot of description on the brain surface together with the description of the functions. That means the epilepsy is always related to the function of the patient. And we want to save the patient, but also save the function of the patient after the surgery. So when you're talking about epilepsy surgery, there is a classification of the level of the epilepsy centers according to the National Association of Epilepsy Centers in the United States, from level 1 to level 4. And if we have to code the level 4 center, it should provide a very complex form of intensive investigations with a lot of expertise, and also have a very comprehensive evaluation before the surgery, and also with invasive EEG monitoring. So this is some of the features that describing the so-called level 4 epilepsy centers, including what surgery has to be performed in this kind of description. And also you can see below there is a lot of surgical procedures together with the staff expertise in this kind of specialized epilepsy procedures. So epilepsy surgery must deal with a patient with a drug resistant epilepsy. It is defined as a failure of adequate trial of two tolerant and also appropriate chosen used epileptic drugs, whether it is a kind of a monotherapy or in combinations to achieve the sustained seizure freedom. And we talk about all the epilepsy patients, composed about 1/3 of the cases who have a drug resistant problem. Drug resistance, of course, will got mortality and burdens. And in papers in US, from US, they calculate is around 0.5 to 1% of the annual mortality rate. And the lifetime mortality is also 2 to 3 times more than the general populations. And you can see the right-hand side, calculate the cost per day for those cases with DRE, and it's almost 3 times more than the usual. And in Hong Kong, we also take care of a number of patients with epilepsy cases. So in 2009, the Hong Kong Epilepsy Society had first published a guideline for our physicians in Hong Kong, talking about how to handle our cases with epilepsy in different ways. These guidelines have been using for a number of years, and until 2018, we have another update about our so-called consensus statement. And one of them is talking about drug-resistant epilepsy and also the pre-surgical evaluation of our epilepsy patients. And in Hong Kong, how's the situation? And there is 2 papers have generalized the occurrence, and also now Hong Kong have a 7 million population, so it comes to around 14,000 up to 62,000 patients that will suffer from epilepsy. When you talk about epilepsy, there is a lot of pathogenesis talking about. One of them is talking about the paroxysmal depolarization shift. Just like action potential, we know in the medical school, if the brain got this kind of action potential trigger and have the shift of that so-called paroxysmal depolarization shift, then the patient will have irritation from one of these area of the brain, and then they will have a trigger towards a onset of the ictal spikes. And it is also related to the so-called high frequency oscillation, HFO, in the terms of frequency 250 up to 500. Another concept about epilepsy generation is the so-called epileptic neuronal network. That means the seizure will be start in a well-defined brain area and will spread towards the area that had a specific neuronal network with that areas, and that's why the epilepsy can be result because of the disturb of this kind of a network interaction, according to this theory. Of course, we are talking about all these kind of things, and we can name it as a brain connectivity and also the brain connectum, I would say. And some of the papers have described 3 kind of different connectivity types in our brain. The first is a localization type. That means that the lesion is just localized in specific area, and if there is something happen, it's only involved that areas. While in the holistic type, all the areas in the brain were connected in some form, and you have a one lesion area, they will have impairment of the functions or in other area at the same time together. But in another kind of the associationist type of connections, that area of lesion only connect with certain areas, and there is not generalized to others. So if you have problem, it's usually around that specific island of the problem. It's a very amazing connectivity. So I would suggest if all our colleagues that have an interest in epilepsy, you can have take a look at the so-called Connectum project with a lot of neuroscience information around. So for temporal epilepsy, this is one of the very kind of well-known problem to epilepsy surgeon. And we define the temporal epilepsy into either is a mesial type or the neocortical type of the temporal epilepsy. And of course, in mesotemporal sclerosis, is one of the most commonest type of problem in mesotemporal areas, followed by a different kind of a neuroplastic, developmental, infective, vascular, and migrational disorder and trauma type of problems. So we are talking about epilepsy surgery. Of course, we have a lot of suggested selection criteria for us to find a right patient for us to treat. So those patients should have a confirmed diagnosis of epilepsy. They have to be medically intractable. They have a very disabling seizure with, we believe there's a receptive foci, except those palliative disconnecting surgery, where we should have a patient that should be motivated and also with motivated relative also. And there is no progression of the underlying cause. And also we have to have a high probability that we can have a better control of the seizure. Then the patient will have a better quality of life. So the pre-surgical evaluation objective is the following. First, we have to identify the so-called epileptogenic zone, which I will elaborate later. And also we have to have strategies to develop to have a safe resection without causing a very significant morbidity to our patient. So here come to one of my favorite diagram, the so-called 6 cortical zones. And you can see the most below one is the seizure onset zone. This is the area that we want to identify. But in fact, this is not only the area. We have a lot of different kind of descriptions, so-called symptomatogenic zone, the irritative zone, and also the epileptogenic lesion altogether. But most important thing is that we have to identify the epileptogenic zone, and beyond the zone will be our so-called arrogant cortex that we have to avoid damaging them. So this is another diagram also showing the concept of the epileptogenic zone. And overall, we define this so-called epileptogenic zone. It is a site of beginning of the epileptogenic seizure and of their primary organization. And this is the way we define it. And then we have to take care of this epileptogenic zone in order to have a good postoperative seizure control. So in different centers in the world, there is a lot of pre-surgical investigation suggestions for the patients. But in general, it's divided into 2 phases. The first phase is to be a so-called compulsive investigation, including the MRI scan, video EEG, and also the neuropsychology assessment. But you can divide all the investigation into 2 objectives. One of the objectives is to have a localization of the epileptogenic zone by means of the MRI scan or those functional imagings, including the PET scan and also the ATOSPET. And another aim of our investigation is to assess the risk of the postoperative defects, including the functional MRI, WADA test, the MEG, and also the spectroscopy in our MRIs. And if the patient go through these kind of investigation, they will be assessed by the epilepsy team, and then we decide whether the patient is eligible for surgery or not. Or if the patient needs it, they will go to phase 2. That means that invasive EEG monitoring by means of different kind of EEG monitoring by our surgical technique. This is another algorithm to talk about the diversification of our patient and whether the patient need different kind of surgery or not. So talking about focal type of seizure and also generalized seizure, and then different kind of surgery, including receptive, neuromodulative, and other kind of a minimal invasive surgery or even radiosurgery treatment. As I said, the pre-surgical evaluation is very numerous, and we can define into non-invasive and also invasive type of investigation that I will go through briefly in the followings. So EEG probably is one of the compulsive investigation for all our cases. The so-called International 1020 system is describing the location of the lead over the scalp. It's either 10% or 20% apart from each lead, and it's a kind of a standard monitoring of our patient from left to right and from anterior to posterior. But however, for intellectual EEG, only less than 50% will show abnormal tracing, and most of them, more than half, will be normal. So that's why intellectual EEG we will do, but it's not very reliable. And some now patients can have a so-called prolonged ambulatory recording, and even now the patient can have a so-called portable kind of EEG that they can have a monitoring at their home, and then the signal can be transferred via cloud system, and then we'll collect more data before the patient was admitted for the video EEG. And for video EEG, probably is one of the gold standard before we interpret whether the patient is suitable for surgery or not. And usually we perform 3 days up to a week time. Occasionally is up to 10 days. And during the period of time, we have to take off the epilepsy drugs, either reduce drug dose or fully take off them, and then let the patient to have seizure happen during the monitoring, and then we'll do the recordings afterwards. And the aim is to have the real EEG spikes happen while the patient got the epileptic foci happened. So I was want to show some video different things. The temporal lobe epilepsy. So you can see this patient now it's got a staring of the eyes, and you can see there's automatism of the hand here. This is one of the most typical type of temporal lobe epilepsy clinical features of the patient. And this is a temporal lobe epilepsy, and this is a frontal lobe epilepsy. You can see there's a very hypermotor type of attack, like the previous temporal epilepsy kind of attack. Very amazing, right? So so the patient underwent video EEG, but before that, the patient must have a very well-performed MRI scan of the brain. And in our hospital, this is the protocol we suggest to the patient, including a volumetric acquisition of T1 weighted images. And we have to follow the log axis of the hippocampus. And then we also need to have the T2 weighted and also the FLAIR sequence of the for the patients. So when we go through the MRI scan, always we have the patient that with so-called MR negative imaging. So what's the reason? We have to ask ourselves why the patient with the MR negative. Is it because of the artifact that downgrade the imaging? Was the recommended sequence have been performed, or was there a subtle lesion that was overlooked? So the solution is to scan with a higher field of the MRI scanner. Most commonly will be 3 Tesla, and in some experimental centers there will be 7 Tesla now. We have to have a standard protocol and to be evaluated by a dedicated neuroradiologist. So this is some of the imaging I want to show you. In 1.5 Tesla compared to the 3 Tesla images. And this is a patient with a lesion, the cortical dysplasia over the temporal stem of the left side here. And also you can see here there is a subtle lesion, the heterotropia here around the ventricular lining that was not easy to be appreciated in 1.5 Teslas. So in MRI, of course, 3 Tesla imaging and also the diffusion tensor imaging is now almost standard in our center to look at the different kind of the lesion and also the volumetric tracts in our body. And also functional MRI is also a must, particularly for patient with the eloquent area that may be involved in the surgical planning, including the motor and sensory and the language area. And also indication of the neural navigation is essential if we want the patient to have a better planning for our surgery. So MEG, magnetoelectrogram, is another investigation. Probably I would say in the future, it is essential for our cases. But unfortunately, in Hong Kong, we don't have this machine. And if our patient require this, we have to subject the patient to the surrounding, like in Guangzhou in China, or going to Taiwan, Taipei, to get this imaging modality performed. So there's a paper compare the EEG finding and also MEG finding, and sometimes we can on top of our usual investigation, we can have more cases that can evaluate our cases and get more knowledge about what's happening inside the brain of the patient. Functional imaging, the PET scan, and also ectospec is also one of the essential part in our investigation to see either intellectual type of the areas or problem, or the ecto type of onset with hyperperfusion areas. And water test is also another test. Sometimes we have to ask our clinical psychologist with our radiologist to perform, and then we have to inject the barbital drugs to paralyze the brain temporarily, and then we have to check the patient's language and the memory by our clinical psychologist. And this is some of the tools that we use to test our patient's memory and language. So a short video show you. Here is our clinical psychologist here, and then tracking the patient before the onset of the drug. Now you can see here. And after the drug, the patient is checked at the investigator again, but see, he is starting to get a bit delay in the response now, and this is one of the function we want to test. So sometimes we will suggest either functional MRI or WADA, depends on the indication of the investigation. So if you have both, of course you can offer both. But if you want to select, sometimes for those patients with mentally impaired that cannot have the functional MRI well performed, then WADA test may help you to have the localization and then lateralization of the language area. And also other clinical psychology tests will be indicated to try to localize the foci correlated to the cognitive deficits. So talking about invasive electrode insertion, there is a number of ways, including epidural, subdural, and parenchymal, i.e. the depth electrode. And also now we are more doing the stereo EEG for our patients. And there is a table showing different indication of the invasive EEG and different types of electrodes that you can consider. The main, of course, the aim is to identify the true epileptic foci and also correlate to the epileptic zone. And then we'll try to use the invasive EEG to map our eloquent areas. So here are some of our patients that have different kind of electrodes inserted for our cases. And this is the procedure we're doing, the resection using the subdural strip by performing the intraoperative ECOG. So I would say this is another important slide that for every epilepsy patient that we think epilepsy surgery might be indicated, we have to go through this multidisciplinary team patient management conference, including neurosurgeon, neurologists, and neuroradiologists, together with our clinical psychologists and with our nurses together. Then we have come up with a conclusion and suggestion for our patient whether he or she need the surgery or not. So talking about different kind of the epilepsy surgery, as I mentioned before, we have curative surgery in terms of resection. We have palliative surgery, including disconnection type of surgery. We have some lesioning method, either use radiosurgery or the laser ablation, or neuromodulative treatment in terms of vagal nerve stimulation, deepening stimulation, or responsive neurostimulations. And this is a diagram showing different kind of the indication related to the site and also extent of the lesion. Then probably you can think of the way to treat the patient. So for temporal epilepsy cases, we perform temporal lobe surgery. This is one of the most common type of surgery. From the very beginning, the classical type of the temporal lobe epilepsy with amygdalohippocampotomy, with modification by Professor Spencer, and with limited temporal lobe resections. And then other kind of variants, including subtemporal approach and Transylvian approach, is practicing nowadays. So this is a diagram showing that the description when you use a classical type or the modified type of the resections is mainly focused on the entry area of the temporal lobe from the middle temporal gyrus down to the occipital sulcus area, and then towards the hippocampus over the mesotemporal area. So this is some of the diagram from our epilepsy textbooks, including the description of the steps in doing the surgery. And then you approach the mesotemporal after taking out the temporal lobe, and then you can see the alignment of the hippocampus from the CA1 towards the CA4. And then we take out the hippocampus and also the amygdala and en bloc. And this is an operative diagram showing the temporal lobe and the base of the temporal loop over here. And then we open up the ventricles, followed by the removal of the hippocampus. And you can see this is the coral plexus. There's a reference. And Transylvian approach is proposed by Professor Yasukil, and also now have been performed widely by some of the centers. And then this is one of the way to try to avoid damage of the Myers loop that I will describe later in this coming slides. And here is some of the description showing how to perform a Transylvian approach to hippocampal area. So this is a summary of the different kind of approaches towards the mesotemporal areas I described before. And this is the so-called Myers loop. Is one of the optic radiation identified in our white matter tracks. And this is the anterior loop of the optic radiation we call Myers loop. It wraps on the roof of our ventricular horn over the temporal area, and then it wraps and going backward towards the visual field cortex. So if you have the problem get involved this, you got a visual field problem, the so-called the pipe of sky defect, like this. And then so this is one of the complications we have to avoid, and also we have to let our patient know, because the pipe of sky defect, if it is severe enough, some of the countries like in the UK, they will affect you to get the driving license because of the visual field defect. So this is the paper, and I was in UK in our elective overseas, and talking about the visual field defect after the temporal lobe epilepsy cases. And we talk about epilepsy surgery outcome. Of course, we have to know Professor Ongo, the so-called Ongo classification, and class 1 means a very good control with seizure-free. And class 4 means there's no improvement or remain or even worsen after your surgery treatment. So there's a lot of papers talking about the different prediction of these surgical freedom, and varies in terms of 60 to 70% of the seizure control for majority of cases. And this is another paper that showing more or less similar, but you can see for location in extratemporal, the seizure control outcome is not that good compared with the temporal lobe cases. And this is another papers talking about the seizure-free outcome on different kind of cases. and also pediatric cases. There's a few papers in this retrospective review also showing a more or less similar percentage of control. All right, so we come to the factors that we think we can help the patient, but finally the surgery failed to help the patient. But any reasons, there's a few that you can consider. First, whether there's any wrong localization of the epileptic zone, whether the epileptic zone is too wide that you cannot reset it completely, or you just reset it limited. For cases with mesotemporal, in fact, there is some papers talking about contralateral and mesotemporal sclerosis. That means you take out the initial suspected area. In the coming future, the patient may have one-fourth of them will have a contralateral side sclerosis changes that will have the seizure again for the patient. So for some advancement of the epilepsy surgery, here are some. So I'm not sure in your centers whether you have it already or not, but these are some of the advancement and have been practicing in the few past years. MR PET scan is one of the new technology, and in Hong Kong it has been introduced only for 2 to 3 years. It helps us to use the PET scan together with the high quality MRI to let us to have the complete localization of the lesion correlate to our MRI structural areas. And this is one of the cases I operate for him. Initially thought to be a MR negative cases, and after this MR PET scan, you can see here there's some hypo active area over the left right frontal areas that we believe this is the epileptic foci, and we had a surgery performed for him, come out to be focal cortical dysplasia type 2B. And also now the patient with good hands in endovascular treatment, they now try to combine the EEG together with endovascular type of probe, and particular more advancement in Toronto Western Hospital by Professor Timo Kleins. And this is kind of different design of the electrode that can be put in endovascular catheters, and hope to put these electrodes while the vessels instead of drilling the skull into the patient's brain. So in the coming few years, probably you can see the clinical result of these kind of the electro monitoring of the EEG signals. So how about SEEG? And it has been performed for more than 60 to 70 years before, but it's not very popular because in around 1980, it was mainly focused on the deaf electrode and subdural grip. So SEEG was not that popular in the past 20 to 30 years. But in now there is a revenge in recent decade, because there is a more physicians and also neurosurgeons now doing more the synthetic EEG, in particular in Cleveland Clinic. There is a lot of publication about the SEEG. And now the patients with refractory epilepsy, there's a lot of patients now is doing more SEEG instead of the traditional subdural strip and grips. And this is some of the implantation map I use for my patient. We divide the brain into left and right, and then into different kind of columns, and then let us to have implantation planning when we do the SEEG. And this is a diagram showing how to do the planning and then do the step in putting the EEG. And here is some of the video I want to show you. And you can see here, this is drilling of our skull bone using a 0.8 millimeter drill bit. Doing just like doing a K-wire insertion by our orthopedic colleagues. Oh, sorry. And then now we put the lead through the drill holes, and then you can see here this is a very tiny SEEG lead, And then the patient after implantation will take an X-ray. You can see this is a patient with bilateral implantation I performed for him. So the SEEG purpose is to establish the so-called anatomical electrochemical hypothesis based on the clinical history, symptomology, imaging, and also the video EEG. And what we want to know is to where the EEG start and where and when it spreads. So the principles here, we want to classifying the ectoclinical symptoms. We want to compare each seizure with those with similar clinical features, like a digestive problem or somatomotor. We want to compare each seizure to different kind of system in that we believe it is correlate. We want to correlate the clinical signs with any whether it's the same or different from our onset of the epileptic discharge. We want to see whether there's correlation of the sign with one or a preferable system or structures. And then, of course, the clinical features and also the symptomatology of the seizures. So this is also talking about the concept of what I talked about, the epileptogenic zone, the lesional zone, the irritative zone, and most particular important is the epileptogenic zone. So here is a different kind of SEEG technique. It's either frame-based or the frameless system, which as I've been using with either BrainLab or Medtronic systems. And also some of the center with robot machine acquired robot assist SEEG is one of the I would say the best way to do it. And in Hong Kong, start from this year, we have centers that have the robot system acquired and help us to have a more accurate implantation of the SEEG and also with better panning. And this is some of the steps in using the one of the robot systems called the ROSA. And then this study compared to the accuracy of the implantation with frame-based and also frameless system, and robot system got a very supreme accuracy in both trajectory and also target localization. And is it safe? Of course, review of this compared to the old traditional type of the subdural strip and grip, and SEEG show very promising with result with only around 1% of the hemorrhagic rate and infection rate. So this is some comparison between SEEG and subdural strip and grip, and also the beauty of SEEG in some of the large centers, they will use the SEEG as a guidance to have a lesioning by means of the radio frequency machine. So this is the step you can have a look from the implantation of the SEEG, and then you review the video EEG result, and then you find and localize the epileptogenic zone. Then you can match your lead with your radio frequency machine, and then you can use it as the guidance for the lesioning of the defined epileptogenic zone or the foci. Then you can achieve the seizure control without open up the brain by craniotomy. So to the final part of my talk, I would like to talk about some of the moderative surgery in epilepsy surgery, and this is the developmental timeline from Professor Penfield, and then towards the recent study, the Santé trial, and have the revolution of the DBS system for refractory epilepsy. So talking about neuromodulative, we have at least three kind of the treatment modalities, namely the responsive neurostimulation, vagus nerve stimulation, and also the brain stimulation. And there is a table compared these three kinds of the treatment modalities. And you can see here SIMS, DBS, and RNS show a bit more superior median seizure reduction according to this review. And in Hong Kong, we have VNS and DBS performed also, and VNS is one of the earliest type of neuromodulative treatment for our cases. And since first case in 1995, we have around 70 cases performed, mainly because the financial issue, and in the old days, the patient have to pay by themselves. And around 7 to 8 years ago, our government start to sponsor our cases that are eligible for VNS. Then we have more cases that can the implantation perform. And in DBS in Hong Kong, we start our first case about 7 years ago, and so far we have 10 cases performed by 2 centers, and ANT is the target so far. And this is some of the discussion of the VNS and RNS, of course. Unfortunately, in Hong Kong, we haven't had these cases performed so far. For DBS, it's thanks for the Santé trial, talking about the efficacy of the DBS. And when we talk about DBS, we have to have the idea about this PET circulation. And then you can see here, this is the correlation, all the networks, and ANT is one of the most important network that that's why the Santé trial aim over the ANT as the trial design. Of course, others targets, including the central medial nucleus of thalamus and other like subthalamic nucleus. Some centers also try to use it as the target for the treatment. And this is the imaging protocol for our cases in our center. If we want to perform DBS for ANT localization. And afterwards, we use imaging guidance, DBS programming, and then we work with our neurologists together to have a better programming for our cases. And this is the Santé trial reference programming parameters that we use for our cases around 2 weeks post-op as this initial starting point. And this is the parameters for all cases. So I would like to end my presentation by showing the great wording from Professor Penfield. And he said that epilepsy, though she wears the frightening mask of tragedy in her approach to each patient, takes off the mask at the time before the physician who has the wish to stop and ponder her riddles. So thank you very much, and I would like to thank my team members in our epilepsy surgery team, including neurosurgeons, neurologists, neuroradiologists, psychologists, and our EDU colleague, and also our epilepsy surgery nurse. And this is my hospital, Queen Elizabeth Hospital in Hong Kong, and this is my contact email. I welcome you all to contact me if you have any discussion want to talk about epilepsy, and you are very welcome to come to Hong Kong to visit us if you have time. And now Hong Kong is getting more safe, and the COVID situation is getting stable. So thank you very much. I would like to end my presentation here. Thank you.
Congratulations for the extraordinary work as well as the presentation. Your presentation is truly comprehensive. You have covered pre-surgical evaluation extensively. You have mentioned about both the surgical techniques, its outcome, neuromodulation, as well as some of the recent advances. I'm not sure how many questions are there in the chat box, but I would like to begin the discussion. I think we have about 10 minutes time for discussion.
Yes.
I'm very keen to know about your learning curve, what all difficulties you went through in establishing such a good program. Can you share with our participants your learning curve as well as your center's learning curve?
Yeah, thank you, Professor Rio. So I would say thanks to my previous great senior neurosurgeons in the past 20 years in establishing the first epilepsy cases handling. And I would say, to be honest, if you have you want to establish a very good epilepsy surgery center, you have to have a strong team, as I mentioned before. The team include not only the neurosurgeons, but all our neurologists, particularly if you are going to use the stereo EEG, because for stereo EEG in particularly, we implant usually around 10 up to 16 lead, and each lead consists around 8 contact up to 16 contacts. So you can imagine it's like the 100 something or up to 200 something contact in your brain. So your neurologists have to be very keen and dedicated with you together to read the EEG, the tracing, and to interpret the EEG finding with you. And also, if your radiologist is a very dedicated person, of course, they will analyze the imaging for you very correctly. Then you can find those subtle lesions. Because I would say the initial starting of our cases usually is that those kinds with a very obvious lesion in your brain, like the mesotemporal sclerosis, or like a carcinoma or some tumor around the brain areas. Then you can easily to identify the workup and also the epileptic foci. But for cases and we're doing more and more, and then you come across very subtle cases, and those so-called MR negative or cryptogenic epilepsy cases, then you have to rely on your teammates and to work out the solution with you together, and also to plan what the implantation so-called hypothesis for you. And also, and as I mentioned, we start doing those deep brain stimulation and vagal nerve stimulation. And these kind of neuromodulative treatment, we also need our neurologists to do the programming together with us so that we can have the best programming of the parameters and get the most best way to control the seizure according to the response of our patient. So this is probably some of the hurdles and also the difficulties in the past few years when I was doing the cases with our teammates. And so I would say people are always the first one I have to consider.
Thank you. Jerome Engel always says that there is enough knowledge about epilepsy surgery worldwide. The difficulty is in translating into action. Now, you are running a very advanced program. Suppose new center in a country with limited resources wants your help. Do you have any collaboration like that? And can you give us some idea how you can initiate and support epilepsy surgery program, basic program in a country with limited resources?
Thank you for the question, Professor. I would say if we want to start the program like the old days in our centers, we start using EEG together with MRI scan. No matter it's 1.5 Tesla or 3 Tesla or more, it doesn't really matter. At least there is a MRI scan together with a EEG. Then you already got information related to neurophysiology of the patient and also the overall structural ideas of the brain of your patients. So these two probably can as a guidance for the treatment planning. And I would say if you have these two modalities, around 50% of our cases under your hands, you can have a screening of them, and then you can have idea what's happening of the patient. together with the semiology of the patient that you talk to him and ask them to take a video and show it to you. Because now I would say having a cell phone that can take a video is not that difficult currently in the world. So having a cell phone taking those videos at their home together with a EEG and a basic MRI scan, I would say you can at least take more than half of your patient that you can have an idea and then could have some preliminary suggestion of your treatment strategy for them. And then you can have more time or the resources, then you can start doing more like video EEG kind of establishment and more those functional imaging. But at least the semiology, the EEG, and also a basic MRI already good enough for you to start those services for areas that have limited resources, like our previous days in Hong Kong.
Yeah, very, very encouraging words to know that any good general neurosurgery center where microsurgery is done can actually initiate epilepsy surgery just with the video EEG telemetry as well as MR scanner. Actually, the investment in epilepsy surgery is more in people than the technology. At least half to 2/3 of the epilepsy surgery can be done with a motivated team as well as team leader. Now, my last point. See, Europe is more heterogeneous and homogeneous, and Asia is more heterogeneous. Now, in European epilepsy brain bank, epilepsy surgery specimens collected all over Europe. A new classification, new genomic study is coming out of that sort of 10,000 specimen data bank. You think, is it possible to initiate such a thing in Asia?
Yeah, I would say this is a very enlightening and good suggestion, because like brain tumor, we in different area of the world, they have their own brain tumor database, and then they will store the specimen and like the glioma as example. For epilepsy, we have a lot of receptive cases, and those specimen probably is one of the precious information for in the planning and interpretation for the future epilepsy cases, and as a reference for other centers. And particularly, I would say in Asia, as a platform, is not impossible to have this kind of ideas and initiative by some of the organizations. Like I'm not sure whether ACNS have this kind of initiative planning or not, but it is a very good idea, and at least in the audience here, I would say everybody would like to have this kind of collaboration in the future. Of course, I'm the first one to support.
Thank you very much. I thoroughly enjoyed listening and learning from you. I'm sure same with all the other participants. Just wanted to check with Dr. Raja. I think maybe this part of the webinar can be completed, and then Dr. Raja can take over. And then thank you very much, Dr. Poon, for the excellent overview of epilepsy surgery. Thank you very much.
Thank you very much. Thank you once again the invitation today, and I hope to see you all either from Zoom or in person in different kind of the conference, or even you could come to Hong Kong and visit us, and we're very welcome. And Ben, of course, will stay with me to welcome you all.
Thank you very much. It was indeed a wonderful session, and beautiful suggestions and for collaborations coming in. We are extremely grateful to Professor Taklak-Mun and Professor Mala Bhaskara Rao for this kind support and time for the ACNS webinars. I would like to inform our viewers that this has been broadcasted on YouTube, WeChat and Zoom. And as of now, we have around 750 people who are watching us live. So I will move. We are extremely grateful to Professor Shubin for broadcasting this on the WeChat channel. We'll move on to the second session, and I would like to invite Professor Masamichi Kurosaki for a short introduction, who would in turn invite Professor Kiling Chang for his lecture. Professor Kurosaki.
Thank you, Dr. Raja. It's truly an honor to chair this session. Let's move on to this session. This session topic is pituitary. As you know, in WHO new classification, the terminology of pituitary adenoma changed to pituitary neuroendocrine tumor, PITNET. Maybe you know, but not so spread among the clinicians. So today's the lecture from Professor Kiling Chang. His title is Integrated Proteogenomic Characterization Across Pituitary Neuroendocrine Tumor. Professor Kiling Chang, please start your lecture.
Thank you, Dr. Kurosaki. It's my honor to present here, and my topic is integrate proteogenomics characterization across the major histological types of the pituitary tumor, which just Kurosaki mentioned is the PITNET. And I just want to share my really newly updated opinion on this tumor. And as you can see, the pituitary tumor is one of the most common neuroendocrine tumor, almost one of the most common intracranial tumor, with the incidence of 17% at autopsy. And depending on the capability to produce the hormones, and the PITNET can be divided into the ACTH, PRL, GH, TSH, GT, and pleurohormone, also as a non-functioning. So in our clinical, depending on they can cause different symptoms, including endocrine disorders like gigantism, acromegaly, and Cushing disease. Also, on the neurological effects, they could cause invasion of the surrounding structures like the neural nerve. And here we mostly use in our clinical work is the clinical pathological classification of these tumor, including the 3 lineage transcript factor mentioned in the WHO 2020, which is the PIT1, TPIT, SF1, and also which is negative for all 3 lineage is the non-cell tumor. And in each lineage, like PIT1, we have 3 hormones like the electrotroph, somatotroph, and thyrotroph. And each lineage has the silent tumor, which means no hormone over secretion, and which is the silent PIT1 tumor, silent TPIT tumor, and a silent SF1 tumor. I will draw here. Yeah. Okay, and the current treatment strategy for this tumor mostly is the surgical therapy, which is the transcranial approach is the mostly used. Also, the transnasal approach is mostly used, and the transcranial approach is seldom used here now. And the pharmacotherapy for GH saccharine tumor is the sum of SSA, and PRL is capgorine. And the radiotherapy is also a process. But however, in all the 3 therapies, they have their limitations. For example, for the large giant PITNET, the low GTR was achieved, and the pharmaceutical perhaps no drugs for the other subtypes, and the radiotherapy still have the recurrence. So when we check the 2022 classification of WHO, we can see there are multiple classification of this tumor, yeah. And the markers of all these classification is actually not very clear. And you can see there is the mature pleurohormone PIT1 lineage tumor and immature pleurohormone tumor, but the exact marker is not very clear. And in addition, the TPIT and SF1, the 2022 didn't separate them into the silent and the secreting. So the hormone secretion is not included in this classification. So this classification only based on the IHC staining, and the high risk, they also suggest some high risk subtypes like spiraless granulocytomas or the electrotroph adenoma in men. But the diagnostic markers and this classification cannot teach us how to treat patients without any use drugs or any therapies. So we process a research on this tumor. We think there are 4 levels of one tumor, including genomics, transcriptomics, proteogenomics, and the modification of the proteogenomics in just like the phosphoroproteomics. So we previously, many research has processed on this tumor, like the GNS discovery of the GNS mutation, USP8 mutation, and the other transcriptomics. So, but none of these research combine all these 4 levels. So here we process the integrated proteogenomic analysis of the PNET. We include 200 PNETs and 7 normal pituitary as a control, and including all the 10 clinical pathological subtypes as we mentioned before. And you can see here we have almost half invasion tumor and half not invasion tumor here. And we can also have the almost 4 lineage here, and all the 10 subtypes was evenly separated. So when we checked our sequencing data, we found from the transcriptome data and the proteomic levels, we can check all the secreting hormones kindly expressed through all these 2 levels. And so let's check the West data, which is genomics data. And of course, we find the 2 mostly observed mutations, including USP8 and the GNS mutations. So next we checked which is consists between these 4 levels, like the CMV, which we call is the copy number gain. And if the copy number gain was got, the protein will be overexpressed, which leads to the overexpression of the protein and cause the function change. So when we checked all the protein we got here, and we found only 21 members have the consistent change. So through this, we also have our old friends, the GNS. So we have here is the GNS mutation is quite common in the PNET, and we also observe the GNS CNA change also is in the PNET. So next, we combine these 2 mutation and copy number gain. We find these 2 events exclusively present in the PIT1 lineage. A GNS mutation was enriched in a GH secreting tumor, but GNS copy number gain was across all the PIT1 lineage tumors, including prolactinoma and the thyroidoma. So when we combine these 2 events, we can find GNS mutation was a gain of function was widely explored, and it was enriched in GH secreting tumors, while the GNS copy number gain was also only caused the overexpression and was present in all PIT1 tumors. And so to see what is the difference between these 2 events. On the left side is the GNS mutation, and we found this mutation could cause the oversecretion of the growth hormone. And when we go to the GNS copy number gain, we find the cell cycle and then DNA replication upregulated, which leads to the tumor proliferation. So with the multi-omics data, we find the download stream pathway through all this. And then you can see one of the gain of function and the other is the copy number gain, although they also leads to the upregulation of the GNS function. The left side and the right side have totally different pathways. And by the way, we also checked the downstream of the GNS copy number gain and the CDK6 overexpression. And the GNS expression and the CDK expression was highly correlated in our cohort. So next we check the classification. We think there are 4 levels. So as you can see on the left side, there are 10 levels. 10 subtypes, as we just mentioned, the clinical pathological subtypes. And when we have a glance at the proteomic levels, we find that there are 3 types, which is the non-cell silent SF1 and the GN, which is mostly SF1 lineage, or the non-cell lineage. They gather together. And the ACTH and the silent TP, they separately present here and here. They present separately, and all the PIT1 lineage, they gather together. This is a very interesting thing we can got here. And so when we see all these together, there are 4 lineages, as we mentioned in WHO 2002. And where we see the transcriptome clusters, we have the totally different clusters. Sorry. totally different clusters. And we can see we have the 5 clusters in transcriptomic levels, and we have 7 clusters in the proteomic levels. And the phosphoproteomic levels, we also have 7 clusters. And we can see that there are 3 lineages. We have reasons for the 3 lineages. The first is the SF1 and the non-cell lineage. Next is the TPIT lineage. And the last is the PIT1 lineage. They have the similar molecular characteristics inside 3 groups, and they have totally different between these groups. So another way we can see here is that there are 2 very complex classification types here, which is in the RNA, there's a hormone. Here, we cannot separate PR, LGH, or TSH in the RNA level. And on the phosphorylation, we identify different unknown subtypes. So next, we decide to focus on the proteomic cluster of this tumor. And when we got insight into the proteomics, which is the 7 cluster, we find that he gathered SF1 and the non-cells into one, and he also gathered TSH and the silent PIT1 into one cluster, as we show here. And it is SF1 and non-cell here. So we first go into the PIT1 lineage, which is here. And when we see the PIT1 lineage, we find there is a very interesting subtypes. He have extremely high invasive rate and relatively high diameters, so which is the invasive tumor. So what we see here is it has the EMT classification, EMT, which is epithelial megacycle transient. And this class of tumors have extremely high stroma. So the staining of stroma may present the invasiveness of PITnet. So to check this one, we have stain on the epithelial and the megacycle markers, and we find in this cluster they mark together, and in other cluster they were separate. So next to discover what is the biomarker of these clusters, we first identify the EMT, which is transcriptor of the EMT, which is this 5. And when we compare with the EMT and the other cluster here, we find they're totally different. We can see in the EMT, these biomarkers are extremely high, and in the other clusters, they are extremely low. So these markers may help we identify this cluster, and we also confirm them with the IHC here. So we can see here in PIT1 lineage, we have 2 clusters, which first is the hormone secreting, which could further divided into the GH secreting, PRL secreting, and TSH or silent PIT1. And the next is the EMT cluster here, and which will lead to the invasive or giant pituitary adenoma in the PIT1 lineage. And next is the TP lineage. Let's have a fast review of our previous work, which is the USP8 mutation. And we previously in 2015 identified the USP8 mutation in the ACTH secreting pituitary tumor, which is the part of the TP tumor. So in this work, these 2 are the ACTH secreting tumors. And on the left side, there are non-TPIT tumors. So we can see here, we also identify the EGFR here. We can see the elevation and the PLMC overexpression here. But for the USP8 wild-type tumor here, which could not be activated through the USP8 mutation, we can see the EGFR ligands. So in the ACTH secreting tumor, we think the activation of the EGFR pathway, which could lead to the ACTH oversecretion, regardless of the USP8 mutation or not. However, in the silent TPIT, which is a very aggressive PITnet tumor, and they have no secretion of the POMC, which is all here, no upregulation of the POMC. They also have the EGFR upregulation, but they through different pathways. The EGFR T693 phosphorylation is unique in this subtype, and which could cause the downstream tumor proliferation, which is missed in the ACTH tumor. So we have 2 different pathways in this tumor, and the EGFR phosphorylation and downstream the PI3K, AKT, mTOR signaling is further verified through the multi-omic level and IHC level. We can see the silent TPIT tumor here. When we use the T693 IHC staining, we can see the unique high expression in this type. So we conclude this, we can find three different subtypes of the TP lineage. First is the USP8, which leads to the ACTH secretion. And the USP8 mutation will cause the POMC oversecretion, and the USP8 inhibitor could be used in this type. And for the ACTH secreting tumor, but has the USP8 wild type, the EGFR ligand is overexpressed, and the EGFR antibody could be used. And for the silent TP tumor here, scientific here is that EGFR T693 phosphorylation and the EGFR TKI could be used for this kind of tumor. And the last is the SF1 and the non-cell. And we can see from the 3 omics levels, these two cells combines together. And when we see the molecular pathways, these two cells showed high expression of the hypoxia pathways and VEGFR, which is, we think, might be the target for these subtypes. So also the downstream of the VEGFR, including these molecules, is also uniquely upregulated in these two subtypes, and they were further verified through the IHC. So for the SF1 and non-cell tumors, we think VEGFR is a target for it. And we have mentioned all the 3 lineage here. And so next we're going to focus on the immune infiltration of PNETs. When combined, when we focus on these biomarkers of the immune infiltration, we could find these 2 interesting things. First is the PD-1 expression. PD-1 expression is widely paid attention to because it's widely used in recent years. And we find in immune exhausted, which is they have extremely low immune cells in these tumors. And another subtype, we have very large amounts of the immune cell, including CD4 and NKT. So we focus on these 2 subtypes separately. First is PD-1. We can see there is a pathway which is the JAK1, SET1, PD-1 axis in the tumor, leading to the PD-1 overexpression and cause the downstream inhibition of these pathways in the white cells, and which is further verified in these tumors. And for the CD4 infiltration, which is the hot tumor, we also call is JAK3 state6, and they extremely present in these tumors and cause the AP1 complex, which is the chemokines which cause the infiltration of the T cells. So for these 2 subtypes in the PD-1 lineage, they are immune exhausted, which could cause by the PD-1 and infiltration tumor cells, which is further leading to the chemokines. Interesting, these chemokines infiltrated tumor cells, most of them were EMT pro, which is the invasion of giant tumor, which leads to that most giant tumor were immune infiltrated, which can be likely used the CAR T. And for the silent PIT1 and the TSH or GH, which we can explore the usage of the PD-L1 or PD-1 antibody. So next, we find these things, including GNS, EMT invasion, EGF activation, VEGF, and immune infiltration. So we validate these findings in another cohort with the 715 patients. And we have the similar results like the GNS overexpression, which may caused by the GNS copy number gain, is also have the worse prognosis and higher diameters. And for the EMT cluster, the EMT biomarkers could lead to the more invasive tumor. And the EGFR activation, including EGFR expression, is extremely high in the TP tumor. And the EGFR T693 was extremely expressed in the silent TP. And last is the VEGFR. VEGFR we can see in the SF1 was significantly high. And for last is the PD-1. PD-1, we can see that all the PIT1 lineage has relatively high, but extremely in the TSH and the PIT1. A previous research also mentioned that PRL and GH have relatively high, but in that research, they did not include any TSH or the silent PIT1. So we think our conclusion was quite consistent with the previous research. And we summarize our results in this table. And to make it more easier to read, we draw these trees to help you to understand our findings. We can see the PINnet could separate into the four lineages as the WHO 2022 suggested. And each lineage have different, one of them, one like TPIT could separate into silent TPIT and ACTH. They are differently, which is the EGF2 T63 phosphorylation. And PIT1 could further separate into four. One of them is EMP, which could lead to the invasion. And SF1 or non-cell could merge into the SF1 and non-cell tumor. And they have different biomarkers for each subtypes. And each biosubtypes could have their different treatment targets. So we have these trees, and we're going to process any clinical trials based on these trees. So next, this article was just published on the research. If you need any further data, you can check it on the website. And I would like to further introduce our site, which is the Huashan Hospital, the West Campus. This campus was built just in 2018. And we have the brand new clinic and 150 beds for the neurological ICU and the neurological operation room, including the IMI. And things use that we also build a gold pituitary joint unit since the 2018. And in this world, we have multiple teams for including the neurosurgery and the endocrine radiotherapy, also including like the GCP, also the phase 1 clinical trials. We share the office and we discuss each one patients together. And we think there's a joint unit for treatment, follow-up, and clinical trial. So this is our experts in the different fields, like the neurosurgery, neuroendocrinologists, and the pathologists. And our process here, for the outpatient clinic, we go to the clinic together, which is the MDT, multiple disciplinary team, which let's take this Cushing syndrome as an example. Let's just confirm the high cortisol levels, confirmed Cushing syndrome. And for the pre-operatory assess, we have the neuroendocrinologist to do this, including including ACTH, 24-hour UFC, and all the things they could do together, and including operative preparations. So after every preparation is good, including for the potassium, and then we do the pre-operations, and our team to do pre-operations. And to mention, we have also processed the joint approach program, like we joint transcranial and transnodal together for the giant tumors. And here is the picture of our team. We have the transnodal surgeon and the transnodal stream here, and the transcranial surgeon also could see the transcranial stream and the transnodal stream both, and we have to join together. And for the post-operative management, we have two teams, including the neurosurgery and the endocrinologist together. Our neurosurgery teams mentioned for like DIC, DI, and the nasal cavity management. And the endocrine pay more attention to what is the hormone things, or what is the potassium or the electrocytes. And the follow-up we do in the endocrine, which is in 1 month, 3 months, 6 months, and 1 year at least. And if the patient is not relieved, and we will have the radiologist join together. And this is the data of actually we have only 2020, but in the last year, we have like 121 patients, and the remission rate was 97%. So I think it's getting better. And thank you. Here's my contact information. And if you need information, I'll as happy to communicate with you. Thank you.
Thank you, Professor San. Thank you. Thank you very much for your nice presentation. At first, my simple question is terminology. As you know, in the new WHO classification, the name of the pituitary adenoma changed to PITNet. But honestly speaking, in Japan, the PITNet terminology of PITNet is not so common, has not yet common in clinician. How about in your country, in China?
Actually, we mostly call it still the pituitary adenoma. But for the basic research, PNET is mostly used now because we have the case of the pituitary neurocarcinoma, and we have to separate them together. And we think the neuroendocrine tumor is a better call of this tumor. Yeah.
Okay, I know. How about in another country?
I think it is adenoma still in most
Yeah,
of the parts.
maybe. But the basic research, maybe he said we usually the Pituitary. How about Professor Liu?
How is it in your country, Liu?
Yeah. I think we still
Nice to see you again, Liu.
Yes. Thank you. I think we still use the conventional term pituitary adenoma functioning and non-functioning.
Still no. Yeah. How about the other doctor?
Dr. Ben?
Yes,
think that
for us,
term-
we are still using a pituitary adenoma.
Yeah, right.
Yeah.
Not yet. No?
But I can see the rationale behind. Maybe there is a shift. May I ask, is PNET is using popularly in China as well? In other hospital other than Huashan Hospital?
Actually, during our conference, the most used is still the pituitary adenoma. But I think since it is a basic research, we have to do these things. I think the WHO changed the name to the pituitary because of the different classification and the molecular characteristics of this tumor. They don't think it's adenoma anymore. They think tumor because it's more aggressive and more difficult to treat as the other adenomas.
Okay. Next, my question is that you mentioned about the genus. As you know, genus mutation is popular in somatotrophic adenoma. Maybe typically the densely granulated type. Which is the difference between densely granulated type and sparsely granulated type in genus copy number?
Okay, GNS mutation was specifically enriched in the GH secreting tumors, but for the copy number gain, it is across all the PIT1 tumors. And it's very interesting that these two different events also cause the gain of function in these pathways. Actually, the GNS mutation will lead to the downstream GNS function, which is gain of function. And the GNS copy number gain will also lead to the overexpression of the GNS protein, which also is the upregulation of downstream. But in our research, we just found they have totally different downstream. The GNS mutation leads to the GH oversecretion, then that's why it is enriched in the GH somatotroph. But for the GH somatocopy number, it is present across all the PIT1 lineage, including the PRL or silent PIT1. And these tumors have extremely large and have the mostly proliferative tumors. And most of them have the recurrence. So they are totally different, but why and what is the total mechanism? We have to do the further research. And I think this may help us to understand the proliferative status of the PNET tumor in the PIT1 lineage. Yeah.
Okay, thank you.
Thank you.
Do you have any other question from the audience?
Ben?
Dr. Ben?
Yes, may I ask another question to Professor Zhang? And I can see, first of all, really a great, excellent research work, and I can see there are so many markers that you try to investigate and really good analysis. So may I ask, because I can see that from your research, you can identify some targets for the treatment for the PNET. And may I ask, in your center, how would you translate in your practice? Because for the PNET, when would you consider using those targets? versus other treatment like radio surgery. So how would you choose between them? Which one you would try to use those targeted drugs?
Thank you, Dr. Ben. It's a very good question. And in our center, we have lots of patients, and most of them have a great outcome after our surgery or the radiotherapies. So at first, we have to process these targets and all the clinical trials on those patients, which we usually call the refractory pituitary tumor adenoma. Yes, which is he suffered from the surgery or the radiotherapy and even the SSA or the other pharmacotherapies, and the patient did not relieve or still have the recurrence of the tumor. So next we try to confirm each marker of these patients, which was already have the surgery. So we have the FFPE sample and confirm the expression of each marker and classified him into the one of the 7 subtypes and to do the further clinical trials. Actually, we have the Timosol and plus the radiotherapy clinical trial already in our center and have tried on several patients. And the results was consistent with our with this result is that the Pit1 lineage have the better results. And for the SF1 or TP, the Timosol is not that good.
Thank you. Excellent work.
Professor Chan said about spoke about the EMT. Do you think the EMT is become a potential marker for the invasive or high risk clinical aggressive tumor? How do you feel about EMT?
Okay, thank you, Dr. Krosky. I think EMT is really good marker, but how to detect EMT is a question. So our center here is to check the presence of stroma cell, and but detect of EMT could not help to treat these patients. So we focus on the immune therapy, and we find there is immune infiltration in these subtypes. So we think for the EMT subtypes, maybe CAR-T or other immune therapy was a choice, and then we could see. And
thank you very much.
We also thank you, Percy. I would have another sentence, but that this work include only 200 patients, and we have very large of data. But we do still think our recent and current classification and the treatment is not that good. We need more work, and I think it's better to combine all our countries and all our center together to have the multiple center therapy or the multiple clinical trials to classify these patients, because this tumor is really complicated.
Thank you very much.
Thank you
for your nice presentation. Okay, Dr. Raja, I'd like to close this session.
Right, thank you very much. It was indeed a very mind-boggling presentation, and we learned a lot from these newer markers. So it's time I'll end this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaita. I would like to thank both the speakers of today, Professor Taklapun and Professor Kiling Chang, and the chairs, Professor Malla Bhaskara Rao and Professor Masamichi Kurosaki, for the time and support for the ACNS webinars. And we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I mentioned earlier, there are around 750 people who have logged in live today. Special thanks to my co-host Liu Bun Seng as well as Ben also for joining in with today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.